Good afternoon, everyone. I thoroughly hope that you guys are enjoying this workshop and are learning lots of different and new skills. So now I'm going to be giving you an approach to the difficult spinal. So the spinal anesthesia and lumbar epidural anesthesia are commonly performed anesthetic and or analgesic techniques with a long track record of efficacy and safety. However, neuraxial blocks can occasionally be challenging to perform. And this is particularly the case if the spinal anatomy is altered or obscured by factors such as obesity, spinal deformities, or even previous spine surgery. So this technical difficulty can result in procedural failure, suboptimal epidural analgesia, and even increased needle trauma. So during this presentation, I'm going to be giving you an approach to the difficult spinal, as well as then showing you the new kid on the block, which is ultrasound-assisted neuraxial anesthesia. So now we're going to start with the basics, being the anatomy. So we're going to focus mostly on the anatomy of the vertebral column, and in that, zooming in on the spine. So the area that I'd like us to focus on is the conus medullaris, which is the terminal ending of the spinal cord. And from this emanates the corda equina, which is so named because it resembles a horse's tail and is the collection of nerve fibers that come off the conus medullaris. I'd also like to bring your attention to the fact that there are 5 lumbar vertebrae, as well as the curvature, which is known as the lumbar lordosis. This is an image of the ideal level where we want to insert our spinal anesthetic, and is referred to as Tuthier's line. So this line is the line that transects the upper border of the iliac crest and is described to be between L4 and L5. This was originally described by Tuthier in the 1900s, and it was originally described as a radiological description. As one can imagine, it can be particularly difficult to palpate the iliac crest in a patient who is obese. Now onto the anatomy of the vertebra. So anteriorly, you have the vertebral body, and posteriorly, you have the vertebral arch. And in the middle, you have the vertebral canal, which houses the spinal cord surrounded by the cerebrospinal fluid. And this is the intrathecal space that we are targeting when we are doing spinal anesthesia. So important bony landmarks are this prominent posterior spinous process. So this is what one can identify on palpation. Then we have the articular processes, both superior and inferior, and that can be more appreciated on this image. It's this over here, followed then by the transverse processes. So when we are doing a midline approach to a spinal anesthetic, we are targeting this space, which is the interspinous space. This can be difficult to achieve when positioning is inadequate. So an alternative approach is then the interlaminar space over here between the superior and inferior lamina of the vertebra. A short diversion, I'm going to quickly talk about the paramedian approach. So this approach is particularly helpful when it's difficult to position the patient adequately in a sitting position. So for whatever reason, for instance, maybe the patient is pregnant and the gravid uterus or abdomen is really in the way of them curving their spine outwards and towards you, therefore opening up this interspinous space, okay? And sometimes also in the elderly, they might also struggle to give you this curvature that ideally you want for an interspinous plane. So from the midline, you first identify your spinous processes as usual. Then from there, you go 1 centimeter lateral from the midline and 1 centimeter superior to the spinous process. And then you enter your needle at a 15-degree angle into the vertebral column, or canal rather. And some texts say that you might need a longer length needle because now you have a longer path to traverse before you get into the subarachnoid or intrathecal space. Yeah, and also this approach is then shown to not need the patient to have that degree of lumbar curvature in order to open up the interspinous spaces, because this is independent of them being adequately positioned. So that can be helpful when you are really struggling to position your patient in the sitting position. Now, going on to the levels that the needle has to traverse before it gets into the vertebral canal. So going from posterior to anterior, we have the skin and subcutaneous tissue. Then we have the supraspinous ligament, the interspinous ligament, and then the famous ligamentum flavum. So as you can see, the needle will traverse all of these layers and go into the canal. Now again, onto the point of positioning. This can be, as you can see, these lumbar spinous processes are angled a bit downwards. And this is how they usually lie anatomically. And by positioning the patient with their chin on their chest and the lower part of their spine, being the lumbar spine, pushed outwards and towards the operator, this then lifts these up and makes them almost horizontal, which is why initially when you are inserting your needle, you should always try first for the horizontal trajectory, which is perpendicular to the skin. And then once finding then that you are struggling, then slightly angulate your needle kephalad towards the patient's head. Then now we're going to talk about the difficult spinal. And these are situations that all make us a bit uncomfortable and shake a little bit in our boots. And these are patients with increased BMI, impalpable spinous processes, elderly patients, vertebral abnormalities, and even previous spinal surgery. As you can see, palpating these iliac crests in this morbidly obese patient will be particularly difficult. And one will really struggle to find the interspinous spaces. And what's suggested in the literature is that, yes, the sitting position is the optimal position for these patients. But what's even more concerning is that our correlation of palpation to the accurate anatomy is very, very dismally off. And what can be even more dangerous and scary is the fact that what you may palpate to be the iliac crest might actually not be the iliac crest. It might just be a fat fold. And where you think you are in L4, L5, you might actually be here in between L1, L2. So extreme caution does need to be applied in these patients. The elderly patient also poses some challenge, and this is also known as the pretzel spine. As you can see, this is a spinal or vertebral column of a patient who has probably lots of osteophytes, has arthritis, and even though the spinal column looks prominent, actually palpating for the interspinous processes, or interspinal space rather, can be quite challenging. And then the patient with scoliosis. So you can appreciate that this is not what we're usually used to seeing. And these patients pose a challenge both because of the fact that their vertebral column is so abnormal, but also even after they've had corrective surgery, they can still pose some difficulty because there's fibrosis due to the surgical site, and there might also be hardware, and these all pose challenges to performing a neuraxial block. Now moving on to ultrasound-guided neuraxial technique. So a meta-analysis showed that compared to the landmark technique, this approach decreased the risk of technical failure and also decreased the number of needle passes. I'm going to be briefly covering the technique. So firstly, one needs to identify the midline. So identifying the midline is achieved by using the curvilinear probe. So initially, one puts this directly perpendicular to the skin and over what one will think is the spinous process. And what you will achieve is this image, which more superficially is the spinous process, and then more anteriorly and angled is a lamina. And then you see that there's quite a deep shadow where beyond you can't see much else. And this is because of the bony shadow, because you are casting your beam directly over the bony prominence. And you can't see anything deeper than that. So in order for you to get a more helpful picture and more helpful information, one needs to then slightly angulate or tilt the probe cephalad. Okay. By doing this, now you get a better window into the deeper structures. So again, from posteriorly to anterior, you have first the dura, okay, and this is also known as the posterior complex, deeper to which you have the spinal canal, and then the anterior complex, which then comprises the ligaments attached to the vertebral body as well as the vertebral body. Okay, lateral to that, you have then your lamina, and then followed by your articular processes. And one can still appreciate that there is a remnant shadow of the spinous process. So this can still help you with identifying the midline, even though now you have better information as to what lies beyond. So secondly, one needs to identify the interspace or the interspinous space. And this is achieved by now orientating your probe in the longitudinal axis. Okay, previously we were transverse, now in the longitudinal axis, and slightly off the midline and with the inward tilt, targeting the window that's created by the lamina. And this is the picture that one achieves. So from caudal to cephalad, you appreciate that there's a uniform opacity or line, followed by an indentation, and then a bony prominence. So now with labeling, you can identify that this is the sacrum. Okay, so one always needs to start from the bottom up because it's much easier to identify the difference between the sacrum and when the first lamina appears. And then this will be marked as the first interspace. And then you'll see that then this is followed by the L4-5 interspace. Okay, so the lamina are the peaked grooves. This is sometimes also referred to as the camel hump, okay, appearance. And on the patient's skin, you'll then be making markings as to where you find the interspace, so the interspinous space, as well as the midline. Remembering that we are describing an ultrasound-assisted technique. So this means that the ultrasound is done prior to the procedure. Then once you've identified these landmarks sonographically, one then proceeds to do or perform the actual spinal anesthesia. So it has been described to do it concurrently, which is referred to as ultrasound-guided neuraxial blockade. But this is a more experimental technique and is considered even more difficult. And sometimes the difficulty even comes in with the fact that you need more than one operator to achieve this. And then lastly, one then needs to determine the needle insertion depth. So once again, we use the curvilinear probe, and what we use are the markings on the screen, okay? And these are usually in centimeters. And this will be used to determine the needle insertion depth. And as per this example, this is 4.2 centimeters. Just to bear in mind that because we've applied the probe on the skin, this already causes a depression on the skin. So this will underestimate the distance by about 0.2 to 0.3 centimeters, so 2 to 3 millimeters. So one needs to bear this in mind. So for instance, since the distance here is 4.2, practically when you're doing the spinal, this means that your distance is most likely going to be closer to 5 centimeters, because now you're not going to have that effect of the probe depressing the skin. And then lastly, I'm just going to briefly mention some other applications of neuraxial-guided, ultrasound-guided neuraxial techniques. So this is particularly helpful in thoracic epidurals, where the anatomy just makes it slightly more challenging to find the spaces. This is because the spinous processes are more angulated downwards. And even by positioning the patient, especially when you get to the mid-thoracic level, even by positioning the patient adequately, it's difficult to get in between the interspinous process. And then for caudal blocks, so this has become also quite popular, and this is considered to be a little bit easier in children because of the fact that their bones are not as calcified yet, and you can actually appreciate more anatomy deeper to the bone than what you do in adults. And then lastly, where my interests lie are with chronic pain blocks. And this is particularly advantageous because of the fact that these blocks are particularly or usually done under fluoroscopic guidance. And what the literature is showing now is that the ultrasound technique is comparable in terms of accuracy as the fluoroscopic blocks. So this means that both the patient and the practitioner are now exposed to less radiation. So that brings me to the end of my talk. I hope that you guys have found this helpful, and here's my email address for you to direct any further questions that you may have, if you're interested in the resources that I've used. And I'd also just like to encourage you to practice, and to practice on normal patients, because then the anatomy is going to be better to visualize. So when you have the more difficult patient, you can at least identify the anatomical structures better. So with that, I bid you farewell.